Acute liver diseases in dogs. Acute hepatic failure. Discuss the clinical signs of acute liver disease and what AHF is, acute hepatic failure. Discuss the diagnosis, the treatment, and the lab results. And then discuss the causes of acute liver disease. Number 1, hepatotoxins, and number 2, infective agents. For hepatotoxins, we have paracetamol, phenobarbital, and potentiated sulfonamides. For infective, we have bacterial and viral. For viral, we have Rubart's disease, which is canine adenovirus 1, and canine herpes virus. For bacterial, we have leptospirosis, Tizer's disease, which is Clostridium piliformis, and Helicobacter. So the clinical signs of acute liver disease: there's a sudden onset with good general condition, so there's no edema, ascites, or cachexia. We can often see vomiting, and then icterus develops quickly. There's fever in the case of infection, and then signs of coagulopathy such as bloody vomit, diarrhea, petechiae, and melena. Animals can also get hepatic encephalopathy and abdominal pain. Acute hepatic failure, AHF, is not a disease, but a clinical symptom caused by different diseases. It often results in a severe disturbance to the liver function. It can be influenced by the age, sex, condition, general health, and immune system. It mostly depends on toxins, the type, the dose, and the exposure. In the histopathology, we can see necrosis. The outcomes of the disease are recovery, or it becomes a chronic liver disease, or we can see death, which is quite often. The aims of the treatment are to stabilize the patient with fluids, electrolytes, and acid-base therapy, support the liver function and stop the initial cause, and to also stop brain edema and hepatic encephalopathy and bleeding. On the ultrasound, the liver appears darker and the gallbladder is distended with sludge. A histopathology can be done after a biopsy, and necrosis of the hepatocytes can be seen. In the lab results, we can see hugely increased ALT and AST. And the causes of acute hepatic failure are hepatotoxins, such as anesthetics and chemicals, infections from viruses, bacteria, fungus, and protozoa and parasites, and it can also be metabolic in the case of pancreatitis, or it can be from trauma, heat stroke, or hypoxia. So in the case of hepatotoxicosis, there is an intrinsic effect and an idiosyncratic effect. The intrinsic effect is when it's dose dependent, so an overdose is required. An example of this is paracetamol. The idiosyncratic effect is not dose dependent. An example of this is phenobarbital. What influences hepatotoxicosis are age, condition, general health, and immune system, and a unique sensitivity to the breed. So for example, Dobermans are more sensitive to sulfonamides, and Labradors are more sensitive to carprofen. It causes chronic hepatitis. Drugs that require liver function monitoring and hepatoprotectants are phenobarbital, phenytoin, and primidone. These are all anesthetics and sedatives. Antimicrobials such as sulfonamides and tetracyclines also require hepatoprotectants. Paracetamol toxicosis is more important in felines, but it can still occur in canine. There is a quick depletion of the glutathione stores, and the toxic metabolites cause oxidative injury and they target red blood cells and hepatocytes. In the red blood cells, they cause methemoglobinemia, and in the hepatocytes, they cause centrolobular hepatic necrosis. The signs are cyanosis and dyspnea, which occurs due to the lung edema. And in the lab results, we can see hemolytic anemia because the red blood cells are damaged, methemoglobinemia, and brown blood. And for the treatment for paracetamol, you give N-acetylcysteine. N-acetylcysteine is the only toxicosis antidote, and it only works for paracetamol toxicosis. In phenobarbital toxicosis, there are normally two effects in dogs. You can have normal and hepatotoxicity. We can see liver enzyme induction of CYP450, which is common. And there's also mild elevation of ALP and ALT. The hepatocytes become enlarged. In the case of hepatotoxicity, we can see acute necrosis or chronic hepatitis in long term. The ALP and the ALT increase by 5 times. In acute cases, the liver becomes enlarged, and in chronic cases, the liver becomes small. The treatment of phenobarbital toxicosis is to decrease or stop the dose, give an alternative medication, such as potassium bromide. In the case of potentiated sulfonamide toxicosis, it's an idiosyncratic effect. It's also dose-dependent, like phenobarbital. It's quite common, especially in dogs. In the case of sulfonamide hypersensitivity, there's a missing gene which codes for the enzyme for detoxifying the reactive metabolites. This missing gene is often in the case of Doberman. So in general, in the case of treating liver toxicosis, stop the drug, give an antidote if it exists, and do a gastric lavage and give charcoal within 2 hours and stabilize with fluids and oxygen. And give an antioxidant such as N-acetylcysteine, which helps replenish the glutathione stores. In the case of infectious diseases, for viral, we start off with Rubarth disease, which is canine adenovirus 1. The virus causes viremia, and it causes acute hepatic necrosis and gallbladder edema. It can also cause blue eye disease and result in uveitis and corneal edemas and glycomas. There is a vaccine which is a cross between canine adenovirus 1 and 2. In the case of canine herpes virus, it affects newborn puppies, so neonates. It's an acute disease. In older dogs, it causes mild upper respiratory signs. In puppies, it causes acute systemic necrosis and hemorrhages. It causes liver necrosis, and we can see intranuclear inclusion bodies in the hepatocytes. In the case of bacterial infectious disease, leptospirosis is caused by Leptospiro interrogans. It is a zoonotic disease. It's an acute disease. It causes acute renal failure and cholestatic hepatic disease. So if a dog presents icterus, fever, and kidney failure, you need to wear gloves and look at their vaccination book. The bacteria is shed in the urine, so be careful. The reservoir is in stagnant water. There is no necrosis or inflammation with Leptospiro. Instead, we see intrahepatic cholestasis. And in the lab results, we can see highly increased ALP and ALT. And the main clinical signs are fever and jaundice. So if there's a fever of an unknown origin and an unexplained renal dysfunction, do serology. A PCR test can identify the DNA of the bacteria. It can also be isolated from fresh urine in dark field microscopy. Tisser's disease, which is rare, is caused by Clostridium piliformis. It causes multifocal hepatic necrosis. And Helicobacter canis also causes multifocal hepatic necrosis. It's mostly found in young dogs. And in the case of parasites, Diarfilaria immitis can cause abrupt loss of venous blood flow, which causes infarcts and then leads to necrosis. And in the case of Toxoplasma gondii, it leads to widespread multifocal necrosis of the liver and leads to acute hepatic failure. The treatment is clindamycin. Also, for hepatotoxicosis in cats, they're badly affected by diazepam and clonazepam. And other drugs that they're affected by are paracetamol and azathioprine. Diazepam and clonazepam cause toxicosis in cats. They cause acute, fulminant, which is a quick onset, liver failure with a high mortality. And for the infectious diseases, they're affected by feline herpes and FIP. For the bacterial, it's the same as dogs, leptospirosis, Clostridium piliformis, and Helicobacter canis. FIP is caused by a coronavirus. It can cause multifocal hepatic necrosis, and the liver is covered in a thick layer of fibrin. This is due to the immune complexes. It is multisystemic and affects the peritoneum, the pleura, the brain, the eyes, and the parenchymal organs. And feline hepatic lipidosis is the most common feline hepatopathy. It generally occurs in an obese cat who is stressed and has prolonged anorexia for 2 to 3 days. For the pathogenesis, so felines are obligate carnivores. They have a high protein requirement. They have active gluconeogenesis. They can't stop postprandial enzyme activity. Dogs can stop it, cats cannot. They also need essential amino acids such as arginine, methionine, taurine, and carnitine. A deficiency in arginine causes high ammonia, which causes hepatic encephalopathy. When there's fasting, they have no energy, no protein, and they can't synthesize lipoproteins, which means lipid accumulation. The cause of this lipid accumulation, so there's increased fatty acid mobilization from peripheral fat stores when the animal's starving or stressed. And when there's decreased carnitine due to starvation, they have decreased fatty acid oxidation. This causes the lipid accumulation. The clinical signs of feline hepatic lipidosis are anorexia and dehydration. It occurs in obese cats that are losing weight. The general signs are nausea and vomiting and icterus. Lipid drops accumulate in the cytoplasm of hepatocytes, which causes enlarged hepatocytes, and they compress tiny bile ducts between them, which causes intrahepatic cholestasis. In severe cases, we can see coagulopathy, and we can also see hepatic encephalopathy. So the cat has depression and has salivation, and it looks like a zombie. In the lab results, we can see intrahepatic cholestasis, and we can also see elevated ALKP, but not so elevated GGT, and expect to see increased ammonia, coagulopathies, which will mean that there's increased PPT, and increased glucose due to stress, and decreased electrolytes, such as potassium, phosphorus, and magnesium. In the cytology, there is no necrosis or inflammation, and on an ultrasound, expect to see hepatomegaly. You can take a biopsy, but it's dangerous due to the vitamin K coagulopathies. For the treatment, forced feeding is a must. You can have the animal 3 days on a nasogastric tube to stabilize them, or a gastrostomy for 4 to 6 weeks on a permanent feeding tube, and avoid refeeding syndrome by gradual reintroduction. And the contraindications: do not give glucocorticoids, as these increase fat accumulation, and avoid lactate, it's contraindicated in liver issues. For the supplementations, give arginine, taurine, and carnitine, and also B12. Cats are very sensitive to hypocobalamin.